Good afternoon, our dear students. Today we continue to discuss Propaedeutics of internal medicine, and topic of our today's lecture. It is continue of a previous lecture about coronary insufficiency, and today I'm going to discuss acute coronary syndrome. It will be more clinical information, some diagnostic guidelines, a lot of about mechanism of coronary insufficiency, and here are specific features for acute coronary syndrome. Plan of our today's lecture it is to give definition, to discuss epidemiology of acute coronary syndrome, risk factors, etiology, mechanisms, classification, clinical investigation, and diagnosis. Okay, let's give definition. Acute coronary syndrome has evolved as a useful operational term that refers to a spectrum of conditions compatible with acute myocardial ischemia or infarction that are usually due to an abrupt reduction in coronary blood flow, ranging clinically from those for ST segment elevation myocardial infarction or STEMI to presentations found in non-ST segment elevation myocardial infarction or non-STEMI or in unstable angina. Most patients with STEMI develop myocardial infarction, Q-positive myocardial infarction, or infarction with Q wave. And few develop non-Q myocardial infarction. It is infarction without a specific ECG sign like pathological Q wave. Most of those without ST elevation develop non-Q myocardial infarction, and only few may develop Q myocardial infarction. The acute coronary syndrome associated with high healthcare costs, frequent recurrences and hospitalizations, and high risk of sudden death and short-term mortality. Okay, what is unstable angina? Now we stop on several forms of acute coronary syndrome. Yes, it is unstable angina, it is STEMI and non-STEMI. What is unstable angina? Unstable angina is defined as myocardial ischemia at rest or in minimal exertion in the absence of cardiomyocyte necrosis. Among patients presenting with suspected non-ST acute coronary syndrome, the introduction of high-sensitivity cardiac troponin measurements in place of standard troponin assays resulted in an increase of detection of myocardial infarction and reciprocal decrease of the diagnosis of unstable angina. Compared with non-STEMI patients, individuals with unstable angina do not experience myocardial necrosis, have a substantially lower risk of death, and appear to derive less benefit from intensified antiplatelet therapy as well as early invasive strategy. Okay, and what is myocardial infarction? Universal definition. Myocardial infarction defines cardiomyocyte necrosis in a clinical setting consistent with acute myocardial ischemia. A little bit specified definition. Acute myocardial infarction is a disease or clinical syndrome accompanying other diseases, which is represented by acute coronary-venous aseptic inflammation of the part of heart wall, and clinically correlates with the stress reactions of body control system, and is determined by extent, localization, nature, and stage of structural transformations in the infarction zone, as well as circulation changes and their consequences. Okay, a little bit about epidemiology. Now I'll give example of several countries. They are spontaneous because I choose just countries with better statistics, with better statistic working. Worldwide, in general, coronary artery disease is the single most frequent cause of death. As in Ukraine, in Europe, in Northern America, and in most other countries, for today, acute coronary syndrome and in general coronary artery disease, it is a first cause of death of adult people. Over 7 million people every year from coronary artery disease, accounting for 12.8% of all deaths. Every 6 men and every 7th woman in Europe will die from myocardial infarction. You see how important the problem, how often the disease, and how important the ability to determine, to diagnose, and find this disease in correct time, and in correct time start treatment. The incidence of hospital admissions for myocardial infarction varies among countries. The most comprehensive STEMI registry is probably in Sweden. There is an incidence in 66 STEMI per 100,000 per year. Here you see a scheme with number of acute coronary syndrome cases trend from 2005 to prognostically probable mathematically calculated to 2049 by sex and age group in the Spanish population. Here you see that prognosis for men before 74, for men more aged, for women before 74 and more aged women. And you see that prognostically we are waiting for increasement of level of acute coronary syndrome in women population and in aged population. Here, quality of life diagnosis depends strictly of diagnostic procedure. It is a relation between troponin and diagnosis of ST elevated and non-ST elevated acute myocardial infarction. Risk factors of acute coronary syndrome. Risk factors are the same for those of other type of atherosclerosis, including heart disease. I showed you previous lecture all these 3 factors for atherosclerosis specifically, and for such a result of atherosclerosis like coronary artery disease. They are the same as for chronic forms as for acute coronary syndrome. And here you see the result of action of this risk factor. Yes, it is a loss of lifestyle, history of patient factors, plus one of the most often it is hypertension in history of patient. Yes, and you remember that it leads to endothelium dysfunction, to atherosclerosis, to angina pectoris, and it can lead to more acute forms, like in the middle of this scheme you see acute forms. It is acute myocardial ischemia, it is coronary thrombosis, myocardial infarction, and like a result, like a complication, it can be arrhythmia and loss of muscle. All these acute form we see like stages of all this process, and if patient not die and not get serious complication at level acute complication at moment of acute coronary syndrome, further it can lead to remodeling, to ventricular dilation, to very severe congestive heart failure, and as a result of end-stage heart disease. Last lecture I told you that coronary artery disease it is the most often problems that lead to end-stage heart disease. Etiology. The hallmark of an acute coronary syndrome is the sudden imbalance between myocardial oxygen consumption and demand, which is usually the result of coronary artery obstruction. The imbalance may also be caused by excessive myocardial oxygen demand in the setting of stable flow limiting lesion. Acute coronary insufficiency due to vasospastic angina, coronary embolism, coronary arteritis, non-coronary causes like hypotension, severe anemia, hypertension, tachycardia, hypertrophic cardiomyopathy, severe aortic stenosis, and non-ischemic myocardial injury like myocarditis, cardiac contusion, cardiotoxic drugs, multifactorial causes like stress, cardiomyopathy, pulmonary embolism, severe heart failure, sepsis, etc. Mechanisms of acute coronary syndrome. Yes, depending, I told you that it can be several forms, and for some forms it will be reversible ischemia, and for some forms it will be irreversible ischemia. If you talk about unstable angina, it develops until local coronary circulation disturbances cross the time of reversible ischemia. And myocardial infarction develops when local coronary circulation disturbances cross the time threshold that make of ischemia irreversible. One more time, unstable angina, it is acute ischemia, but it's not still necrosis, it is reversible, and in case of revascularization, of renovation of normal blood flow in coronary arteries, function of muscles, function of myocardium return to normal. For if it myocardial infarction, if we name it infarction, it means that it is necrosis. It is irreversible damaging of myocardium, and even if it will be revascularization in this moment, some part of myocardium will not return its normal function. Key moments in mechanisms. Mechanism of an acute coronary syndrome was selected by evolution and consist at systemic and local levels. These mechanisms are aimed at providing most favorable of possible the acute coronary syndrome courses. Their disturbances build complications of the acute coronary syndrome. At systemic level, the response of body systems to an acute coronary syndrome is realized through stress and manifests itself as brain-mediated sympathetic activation and increased functional activity of hypothalamic, pituitary, and adrenal system with the change of functions of all target organs. Course and outcome of acute coronary syndrome, all other conditions being equal, an adequate organization of stress or eustress becomes of primary importance. For STEMI, leukocyte reactions are important for the further development of the process. These reactions are triggered by the ejection of leukocytes from the depot to the systemic blood flow. Since the depot mainly contains neutrophils, leukocytes appears at the shift in cell count. Neutrophils are activated and migrate to the infarction zone by positive chemotaxis. Infarction zone products getting in the blood flow play role of attractants for them. The activation of neutrophils appears and hyperenzyemia, higher contents of eicosanoids, leukotrienes, in particular protein carbohydrate complexes, and other biologically active agents. Stress is changing as the process develops and leukocytosis declines with the leukogram changes. Granulocyte counts decrease and their functional activity is suppressed, while the granulocyte counts and their activity increase. Yes, you should be important during blood investigation, during blood test with all these changes. In CBC, you can see these changes and it will help you to confirm your diagnosis acute coronary syndrome. The structural change of the leukogram is the result of controlling effects of infarction zone products getting in the blood flow, neutrophil decay products from the infarction zone, and repellents for neutrophils and attractants for granulocytes. As a result, an enzyme level in blood falls while the protein and protein-carbohydrate complexes content grows. There are the systemic manifestations of an inflammation process in the infarction zone. With the termination of an acute myocardial infarction phase, regulation problems disappear and not a trace remains on the stress. Okay, changes in mechanisms in local level. Local level for myocardial infarction and acute coronary syndrome, you understand it is the heart and specifically myocardium. In this picture, the top panels show the infarction zones and the bottom panels show the border. It's like peri-infarction. You understand that at moment of infarction, moment of necrosis, it will be some middle zone of this acute hypoxia, acute ischemia, and there will be necrosis, and around it, it is a cell with still reversible changes. They are ischemic, but they are not dead. It's not necrotic at that moment, and it always morphologically we will see that it will be infarction zone, like a zone with necrosis, and around it is zone with acute ischemia or border zone, core zone and border zone. The components of pathologic process are not only changes in the infarction zone and recovery of heart shape and size, but also adaptive changes of heart biomechanics. Infarction zone. All that happens is inflammation. Yes, by its source, by its nature, it is inflammation. I hope you know from pathophysiology that process of ischemia, process of necrosis and infarction of tissue, by its nature, it is inflammatory process. Spatial aseptic alternative, but it is still inflammation. The first one is ischemia, reversible myocardial changes or non-STEMI. The transfer to irreversible changes or to STEMI marks the onset of necrosis, and with the transfer from ischemic changes in the infarction zone to the necrotic ones, the inflammation starts in accordance to its traditional scheme. The necrotized myocardium undergoes destruction and decay products and removed through the peri-infarction zone. The necrotized myocardium is specifically destroyed by neutrophil getting by chemotaxis from blood into the infarction zone and producing catepsins. The migration rate is rather high, about 2-4 mm per hour, and even the largest possible infarction is infiltrated by neutrophils in 6 hours at the most. At the same time, fibroblast precursors enter the infarction zone and recovery process begins. It is impossible to separate necrotic and reparative process. They go with each other in the same moment, in parallel and in balance to each other. And look at them as individual ones. They are synchronized and interconnected not only in the level of infarction zone itself, but also at the systemic blood level. The result of a natural inflammation course in the infarction zone is the formulation of full-fledged scar in a place of necrosis. Maturation of granulation tissue results in its consolidation, followed by decrease in infarction zone sizes. Depending on conditions, they can decrease by 25% or more. I should remind those who want to strongly intervene the infarction zone that the phenomena occurring there, it is inflammation, compensatory and adaptive responses, a protective reaction originates as a result of evolution. The moments, all this process, by nature, they are pathological process, but by the whole meaning, it is reparative, it is normal course of disease that lead to renovation and lead to recovery. Yes, it is evolution of myocardial infarction. All these acute, all these inflammatory problems, this zone should go through for normal recovery and normal scar formation after. We may intervene in this process, but carefully. Systemic mechanisms and the infarction zone are interconnected through the peri-infarction zone, first of all through its microcirculatory bed. Wastes from the infarction zone are removed through it, and the products necessary for reparative processes enter in the same way. The larger the infarction-peri-infarction zone interface, the better the mutual effect of the infarction zone and systemic control. It is what about peri-infarction or those border zone. The peri-infarction zone can't be smaller than that required for uncomplicated healing of the infarction. It is necessary and it must be for normal scar formation and normal recovery after MI. What about heart shape and size? In the case of infarction, part of the myocardium becomes disabled and its functions should be compensated. Hypertrophy of an intact myocardium develops. Healing of the infarction zone accompanied with the consolidation of scar leads to a decrease in its size. The heart shape is remodeled, and in such way its anatomic proportions are restored to favor its pumping functions. In the best case, the traces of infarction are difficult to reveal even after thorough investigations. Acute myocardial infarction is a complex and vulnerable process. In the most optimistic estimations, its complications are observed somewhere in a quarter of cases, if it is diagnosed and treated correctly. The immediate cause of complications is inadequate stress or distress. Have little patience, and we would see how distress is realized as complications. Standard mechanism of complications. The cause of complications is hyperreactive or hyporeactive or intermittent distress in this recovery process. The mechanism of complications, irrespective of distress type, is always the same, including desynchronization of necrotic and reparative processes. Desynchronization of necrosis and reparations leads to the loss of heart wall strength in the infarction zone with a cardiac aneurysm or heart rupture outcomes. Let's discuss more each type. What about hyperreactive stress? The result of hyperreactive distress in the intensive and rapid migration of polynuclears in the infarction zone, with acceleration of necrosis and destruction of infarcted myocardium, and lag behind of reparative processes. There is desynchronization. Fast destruction of myocardium in the infarction zone has one more consequence. With high concentration gradients of all products formed in it along the boundary with peri-infarct zone with the electronic instability of a heart and, as a result, arrhythmia. And opposite situation, it can be hyporeactive distress. In this case, everything develops slowly. Systemic reactions are sluggish or are absent at all. Thus, there are problems with the infiltration of polynuclears in the infarction zone, and the necrotic phase is slow, which leads to the delay of reparative processes and their slow development. There is a desynchronization again. Hyporeactive distress with a sluggish disease pattern determines large sizes of aneurysm, and as a rule, heart rupture occurs in the thinnest area of aneurysm. And another type, it is intermittent distress. Intermittent distress means superposition of the above mechanisms by the formula, out of the frying pan into the fire, and everything becomes much more dangerous. Let's discuss classification of acute coronary syndrome. We can find it in chapter 11 of International Classification, chapter 9, International Classification of Diseases. It is chapter about diseases of circulatory system and codes of ischemic heart disease. It is from I-20 to I-25, and unstable angina, it is I-20.0, and I-21, it is myocardial infarction, ST elevation and non-ST elevation. I-23, it is certain occurrent complication. We can quote here complication of acute coronary syndrome, and I-24, it is other acute ischemic heart diseases. Okay, this classification I told you previously. Let's repeat. All acute coronary syndromes can divide on three types. It is STEMI or ST elevation myocardial infarction that caused by occlusive thrombosis, and it goes with ST elevation, and in most cases with pathological Q waves on ECG. Here will be present cardiac enzyme elevation. You remember from previous lecture the scheme, and you remember what kind of cardiac enzymes we can check for diagnosing of myocardial infarction. Non-STEMI or non-occlusive thrombus. It will be no ST elevation. In most cases it will be no pathological Q wave, but it is present cardiac enzyme elevation, because some zone of infarction and some zone of necrosis present. And last type, it is unstable angina or non-occlusive thrombus. It will be no ST elevation, no pathological Q wave on ECG, and it will be no cardiac enzyme elevation in the blood. Classification of myocardial infarction by the anatomic perspective. It can be transmural and non-transmural. Non-transmural can be subendocardial and subepicardial. By the localization, it can be anterior, lateral, posterior, septal, inferior, and infarction of right ventricle. It is most often causes localization, small localization I showed you on previous lecture. By clinical periodization, the stages of MI from the beginning, it is acutest. MI, usually it goes like unstable angina, it is still no elevation of enzymes. Acute phase, it is predominance of necrotic processes. Subacute phase, it is predominance of reparative processes. And post-infarction period, it is period with consolidation of post-infarction scar. Classification by the course, it can be non-complicated and complicated. And complicated by the mechanism can be hyperreactive by its type and hyporeactive. Symptoms. The cardinal symptom, it is chest pain experienced at the thinnest around the chest and radiating to the left arm and left angle of the jaw. This may be associated with diaphoresis, sweating, nausea and vomiting, as well as shortness of breath. All these symptoms we discussed on previous lecture. In many cases, the sensation is atypical, with the pain experienced in different ways or even being completely absent, which is more likely in female patients or those with diabetes and in smokers. Yes, you should remember about silent myocardial infarction or infarction without pain. Some may report arrhythmia, anxiety, or sense of impending doom, hunger, anemia, and feeling of being acutely ill. The description of chest discomfort as a pressure has little utility in aiding a diagnosis, as is not specific for acute coronary syndrome. Pain is not specific. Okay, common localization and patterns of chest pain you see on these pictures. The characteristics of discomfort related to chest pain may be divided into four categories: location, character, duration, and relationship to exertion and other exacerbating or relieving factors. The discomfort caused by myocardial ischemia is usually located in the chest, near the sternum, but may be felt anywhere from epigastrium to the lower jaw or teeth, between the shoulder blades or in either arm, in the wrist and fingers. Distribution of acute coronary syndrome by localization. You see that most often it's localization of obstruction in left anterior descending artery. It's nearly half of all cases. And another name, it is artery of sudden death. It is very often cause of a manifestation of coronary disease from the death. You remember from classification, it is sudden coronary death. More rare, but quite often too, it can be obstruction with infarction in the zone of right coronary artery. It leads to posterior infarction because this artery involves posterior septum. And more rare, just in 20% of cases, it can be obstruction of left circumflex artery. It usually leads to lateral infarction. What should we ask in history of patient? The history should include any current symptoms and a complete inventory of comorbid conditions. An inventory of cardiac risk factors and a complete family history are essential components. The history should also include information about the character, location of discomfort, radiation of discomfort, associated symptoms, and precipitating, exacerbating, or alleviating factors. The importance of family history should not be underdetermined. A detailed assessment, particularly of first-degree relatives, for the presence of coronary artery disease and age of diagnosis is imperative when evaluating a patient's risk factor profile. During physical examination, the result of physical examination of the patient may be entirely normal. The presence of multiple risk factors of atherosclerosis symptoms increases the likelihood that a chest pain is related to myocardial ischemia. The evaluation should include measurements of blood pressure and ankle brachial index, cardiac and carotid arteries auscultation from roots. Examination for the chest wall, neck and shoulders for deformities and tenderness may be helpful in diagnosis musculoskeletal chest discomfort. The physical examination may help identify comorbid conditions that impact therapeutic risk and decision making. What in clinical investigation we can find in comparison myocardial infarction versus stable angina? By the symptoms, by occurrence of pain. For MI, it occurs at any time. For stable angina, it usually occurs due to physical and emotional stress. I showed you last lecture. By modality of pain, for MI with damage to the heart and usually described as severe, steady and crucial. For stable angina, it is with no damage of heart. For outcome, MI can be fatal, and stable angina usually not fatal. By relieving myocardial infarction, symptoms persist even after rest, even after nitroglycerin. And for stable angina, they are usually relieved by rest or nitro within 10-15 minutes. Duration of pain, it usually lasts more than 15 minutes. For stable angina, it usually less than 15 minutes, and discomfort is transient. It usually lasts several minutes or 3-5 minutes and relieved just by stopping or nitroglycerin sublingually. Here you see ECG changes for non-complicated myocardial infarction. What can you see here? First picture, first complex, it is nearly normal complex. You see P wave. After it is complex, we name it QRS complex. Usually here in this complex, Q wave, first negative wave, is very small, or in real ECG it invisible at all in most cases. After it will be ST segments that have to be on isoline in the same line of all ECG, and after it positive normal T wave. What we see in next picture, you see that here Q wave become wider and become deeper. We name it pathological Q wave. QRS complex not return to isoline, yet it finish much more upper, and ST segment till T wave it goes in the line upper the insuline. We name it ST elevation. What we see here, third picture, Q wave, it become even more deeper and more wide. It is changes of myocardium. It usually showed us is irreversible changes, and we understand that this Q wave, even after recovery of patient, will be present in ECG of this patient during all his or her life. But ST segment have a little bit other form. It is still present, the elevation of ST segment, but in the end of this wave you see that it is starting of negative wave. It will be negative T wave. It is a sign of normal progressing, normal evolution of myocardial infarction. It all show us all those changes that we discuss in mechanisms. Next picture, it is progression of the process in time. It is subacute period. It is formatted a Q wave, big deep Q wave, and you remember that it will be constant sign. Q wave will be present further in post-MI patient, but ST segment become lower and it is gradually returns to isoline, and it become more deep negative Q wave. Next picture, this process progressing, ST segment returning till it become one more time on isoline like a normal health person, but it's still present a negative T wave. And last picture, it is complete recovery and normal scar formation after myocardial infarction. What we see here, it's normal P wave. It is a saved pathological deep Q wave. It is sign of post-MI changes. It is sign of scar, of irreversible changes in myocardium. But after it is quite normal R wave, S wave, ST returns, and it is absolutely normal on isoline, and we see nearly normal positive T wave. It is post-MI patients after recovery. One more time, by localizing of myocardial injury, where can we see changes of ECG? You remember that standard ECG has 12 standard leads. Yes, it is 1, 2, 3, AVR, AVL, AVF, and chest leads from V1 till V6. And according where you see these changes, this ST elevation, presence of Q wave, changes of T wave, by the ECG we can localize place of myocardial infarction. Is it lateral, is it septal, anterior or inferior? Complications of myocardial infarction. Complications may occur immediately following the heart attack and may need time to develop. Acute complications may include heart failure, aneurysm of the left ventricle myocardium, ventricular septal rupture of free wall rupture, mitral regurgitation, in particular if the infarction causes dysfunction of the papillary muscle. Dressler's syndrome, please read what is it. It is autoimmune syndrome after myocardial infarction. The abnormal heart rhythm, such as ventricular fibrillation, ventricular tachycardia, atrial fibrillation, and heart block. Longer-term complications include heart failure, chronic congestive heart failure. It can be atrial fibrillation and increased risk of second or recurrence of myocardial infarction. Outcome of acute coronary syndrome. Yes, here you see by the time what it can be in acute period. First day, it is danger for sudden death, sudden coronary death, or for acute arrhythmia, especially ventricular arrhythmia. I showed you last lecture. During first week, it is early complications too. In most cases, it can be arrhythmias, it can be heart failure, shock, or heart rupture. And during year and after the year, it will be more late complications. More than 70% patients undergo a congestive heart failure. Some of them get arrhythmias, heart aneurysms, or thromboemboli. And further, during years and after even 10 years, it will be chronic left heart weakness because of not normal structure and not normal function of ventricle wall. It can lead to congestive heart failure, to recurrent infarcts or arrhythmia. Diagnosis. We should do blood test for cardiac biomarkers. First of all, here you see schemes for troponisms by the day, by the time. Remember a previous lecture I told you that they are not early, very early for during first day and first hours. We need MB fraction of creatine kinase, and for earliest we can use myoglobin. Additionally to biomarkers, we have to determine white blood cells, cholesterol levels, and C-reactive protein levels. Of course, we must do ECG, electrocardiogram. I showed you symptoms. It is one of the criteria for myocardial infarction and other form of acute coronary syndrome. We should do B-mode, Doppler, and intravascular ultrasound. It have to be done vascular catheterization and angiogram or coronarography, and it can be done other imaging tests. Initial assessment of patient with suspected acute coronary syndrome. What we have evaluated, first of all, it is presentation. Yes, it is presence of clinical symptoms, like in most patients it's pain. It is ECG changes, what we discuss, and it is presence of cardiac biomarkers, the most specific of them troponin. And the diagnoses have to be complex. Based on these three steps. It is clinical presentation, it is ECG changes, it is troponin levels, and according to it we can determine is it maybe it is no cardiac problem at all, or it is unstable angina, or STEMI or non-STEMI, or some other cardiac problem. Criteria for diagnosis of myocardial infarction. A combination of criteria is required to meet the diagnosis of MI, namely the detection of an increase or decrease of cardiac biomarker, preferably high-sensitivity cardiac troponin, with at least one value of above the 99th percentile of the upper reference limit and at least one of the following. What it will be? Symptoms of ischemia, new or presumed new significant ST wave changes or left bundle branch block. Acute left bundle branch block, it is equivalent of ST segment elevation or 4MI. On 12-lead ACG, development of pathological Q waves on ACG, imaging evidence of new or presumed new loss of viable myocardium, original wall motion abnormality, intracoronary thrombus detected on angiography or autopsy. Cardiac biomarkers. I showed you this picture in last lecture. Yes, the most specific and informative for us it is troponins T or I, more early CKMB, creatine kinase, more early myoglobins, and more late it is LT, ST, LDH, but they are not specific at all. Cardiac troponin I and T have displaced myoglobin and creatine kinase MB as a preferred markers of myocardial injury. It's what I told you. Serum levels increase within 3-12 hours from the onset of chest pain, peak at 24 and 48 hours. You understand, for acute phase it is too late for us, and return to baseline over 5-14 days during 2 weeks. Troponin levels may not be detectable for 6 hours after the onset of myocardial cell injury. The most sensitive early marker for myocardial infarction is myoglobin. Troponin levels should be measured at presentation and again 10-12 hours after the onset of symptoms. When there is uncertainty regarding in the time of symptom onset, troponin should be measured at 12 hours after the presentation. The risk of death from an acute coronary syndrome is directly related to troponin level, and patients with no detectable troponins have a good short-term prognosis. Elevated troponin levels can occur in patients without acute coronary syndrome. It can be false even with such specific enzyme like troponin. They are associated with adverse outcome in many other clinical situations, including congestive heart failure, it is very severe or acute course, it is sepsis, acute pulmonary embolism, and chronic kidney disease. Other cardiac causes include myocarditis and aortic dissection. Here you see one more time changes on ACG. There are ST and T changes in lead 2, 3 and AVF. It by solid red circles. It is a suspicion of ischemia of inferior myocardial wall. Leads 2, 3 and AVF are responsible for inferior wall. Similar change is outlined in lead V6. Here in an example of STEMI in acutest phase, you see just starting of formation of pathological Q wave and ST elevation, and it is inferior to, it is positive in second, third in AVF. Here are the inferior STEMI 2 with the right bundle branch block on ACG. And reciprocal depression in lead 1 and AVL. Reciprocal, or it means opposite changes, opposite from the infarction zone. And criteria of differentiation of non-complicated and complicated MI. What criteria we need? It is blood leukocytes, results in a first day and during further dynamics. Yes, if it is from 7 to 11, it is non-complicated, more than 11 complicated hyperreactive, less than 7 complicated hyperreactive. We can do the same criteria for short of leukocytes, for time of maximum activity enzymes, for initial period of protein carbohydrate complex growth, for the period of reaching maximum protein carbohydrate complex concentrations, by the interval between maxima of enzymes and protein carbohydrate complexes, and by the return of ST segment on ECG to the ESA line in hours. And in this table you can see the symptoms, how to early suspect if patient has complication or high risk of acute or chronic complication, or don't have, just by these early symptoms. And even you can differentiate, is it hyperreactive complicated or hyporeactive complicated. Okay, and for today that's all. It's all information in this lecture about acute coronary syndrome. As usual, I'm waiting for your questions and maybe some comments in comments under this video on YouTube or at our Facebook page of our department. I'm waiting for discussion, and everyone who listen lecture, please write your name and number of group under this video. For today that's all. Good luck in your further education.